in a couple of weeks' time dedicated to going through these findings. But what we sort of wanted to do today for you all was to give you a little bit of an idea as to what the project entailed and where it came from originally. To give you a bit of context, my name's Stan, a project manager with the NHS Benchmarking Network, and I've been leading our acute pharmacy and medicines optimization project for a few years now. And we've historically had other types of organisations participating in that project, but as of the last sort of 10 years or so, we've very much kept to acute providers for equal comparison. And so I suppose came the birth of the Mental Health Pharmacy Project. And I know there's a few pharmacy colleagues on the call, so please do bear with me with this presentation. It's a bit of a taster for what may be to come in a couple of weeks' time when we do have that dedicated session. And I will share any relevant documentation and things for that session after this presentation. So I thought to begin with, maybe a bit of context may be useful. And again, to kind of touch on that history. So we have benchmarked mental health pharmacy provision previously as part of, as I mentioned, that pharmacy and medicines optimization project that we deliver in the network. And that's been running since 2014. So it's very long standing. It's got very, very good engagement in the acute space and did have previously, as I mentioned, between 2014 and 2016 in the mental health and community spaces as well. Since 2016, we kind of reverted to just looking at acute provision, and there was a few reasons for this, primarily due to the fact that the impact on costs and medicine costs was so huge in the acute sector in comparison to some of the others, and so we dedicated the resource into trying to look there. But there's always been appetite for mental health pharmacy provision in some way as well, and so we have been listening to the kind of voices that have came from our members, and that's where this has come from, I suppose. You can see there that second bullet point on the left-hand side. So we were approaching around about November from a group of providers in the south of England, so that being the southeast and the southwest. And essentially, the chief pharmacist got together and asked if it was possible for us to implement some sort of mental health pharmacy exercise. And we went away and sort of tried to plan how that might look and what that might entail if we were to be able to fit something into that member program. And that scoping was completed between November and March. So November 2024 of last year and March 2025 of this year. And like I said, there was a lot of back and forth to decide what that might look like and what it may entail. Um, and I suppose moving on to the second point there, the project, what we came up with was a sort of pilot exercise. So we're going to give this a bit of a go and see what engagement we get, and to really focus on the workforce in mental health pharmacy. That was a sort of big demand from that group from the south of England. And what we tried to do was collaborate with those organisations, apologies, to come up with what we thought would be a successful project and really give the value to those organisations that have submitted, but enable a bit of feedback and iterative development on top of that. So as I mentioned, the project that I'll cover today looks at the workforce that are supporting community and inpatient mental health services, and that is pharmacy specific workforce. The data is between April of 2024 and March of 2025. And we have actually just issued the bespoke reports for any organisation that took part in that project. So they're available on the members area. If there are any organisations that didn't take part but are keen to see what sort of metrics came out of it, again, I will touch on some today and some more in-depth data in a couple of weeks' time. But there is an overview report available on that project homepage as well, which Sharanya has just kindly shared in the chat. So thank you, Sharanya. So participation was absolutely fantastic, given that it was a first iteration. And again, we kind of started with nothing. So submissions were received from 40 providers across England and Wales. So some really, really positive engagement there. And there were also interest from some of the other nations and things as well. So again, it was a very early start, something we wanted to see what kind of engagement we get and what input we'd have into those conversations. And we came out with 40 submissions in total, which was fantastic. The data, as some of the other colleagues today have touched on, represents quite a large sample size, actually. So of those 40 organisations, The data covers a total of 1,863 whole-time equivalent pharmacy staff. So an awful large number of staff being covered in the collection. 357.8 of those were dedicated to supporting inpatient services, and 319, 320 roughly, were dedicated to supporting some of those community services. And I'll touch on exactly what's included in those types of services in a moment's time. So again, just to give you a little bit of background as to this project and how it kind of evolved, because it sounds quite complicated given we started in 2014 and we've chopped and changed since then. So in 2014, we had the Pharmacy and Medicines Optimization Project, and that was the first iteration. So we've now been running for 11 consecutive data collection years. Um, it covered acute community and mental health, and it was a very high level data specification to begin with. So covered a large range of data points, but not necessarily anything specific to any of those sectors. And that was part of the challenge, really, was trying to extract the value. In 2018, we redesigned that project. So between 2014 and 2016, those organisations could take part. 2017, we took a year to decide what we might do with that based on feedback. And 2018, we redesigned that. So we removed community and mental health, and we came up with a very targeted data specification. So from 2018 till present, that has been now been an acute pharmacy and medicines optimization project. So it's very long standing. We get really, really good engagement from across the nations in that acute sector space, and it's very targeted. We have a really good focus group that engage with us and design the specification alongside ourselves. We have NHS England input into some of that as well. So we've got a really sort of strong standing project there, and we get some really useful outputs for the organisations that take part in that. And I think that's what led to the demand for a mental health project is those mental health providers have seen some of the value of the acute project to those acute providers, have seen it from previous iterations in 2014, what it may be able to offer. And so we're really interested in doing something similar. And that's where we've come up with this pilot exercise. So again, it's a workforce focused, and it was very much a collaborative process to decide what this project and what this pilot may look like moving forward. So I'm sure a lot of people have come for the data, so we'll have a quick look at some of that. And again, as I mentioned, we are doing a dedicated findings event on the 25th of November. So it's a lunch and learn session, a dedicated 45 minutes. So if people do have more specific questions and curious on what the larger scale outputs may be, then please do get in touch with us or follow that link that Shirani's put to find some of those outputs, and we will share it in that session. So the first thing was looking at workforce planning, really, and we were trying to capture whether organisations carry out some of those planning initiatives that we find in the acute sector. And we found that roughly 33% of organisations will carry out capacity planning for their clinical services in pharmacy. And that 65% were using e-rostering. Now, we also collected e-job planning as well, something slightly different and something that we've seen in acute documentation. And the mental health providers were really keen to see whether their organisations or if any of those organisations used those initiatives as well. For e-rostering, as I mentioned, that was 65%, but for e-job planning, it was actually at 0%. So there are space there for some thoughts about how those initiatives may evolve moving forward. So as I mentioned, we collected data for both community services, so the workforce that are dedicated to supporting some of those community services, and the workforce dedicated to supporting some of the inpatient services as well. I've got a list here to give you an idea of what's actually involved in the community services, and I will pop that in writing in the chat after this. But we looked at generic CMHTs, we had crisis resolution or home treatment teams, perinatal were involved in there, CYPMH community teams, LD community teams, and then anything other we kind of grouped together again, given this was high level and a first stab at something. And I will touch on what the inpatient ones are when we get round to that. So they're the types of services that some of these staff that you'll find are supporting. So on the left here, we've got the total whole-time equivalent pharmacists supporting those CMHTs. So this is all of that list that I've just mentioned. And you can see that in the community sector, there's around a median of zero point 0.5 whole-time equivalent per 100,000 population, but quite a spread of rate of data actually. So the range goes from around about 1.4 whole-time equivalents all the way down to some organisations just above zero. So very little dedicated pharmacist staff that are supporting those services. On the right-hand side, this looks at total pharmacy staff. So that includes pharmacists, pharmacy technicians, and pharmacy assistants. And you can see that the number changes slightly. So it's now an average of 0.68 pharmacy staff supporting services, with again quite a large range. So you'll see that some organisations right up there at nearing two whole-time equivalents, and then some again still just sat above zero staff. So very few dedicated to supporting their CMHTs. And I think what it shows and what we really wanted to get out of the project was for organisations to understand where they sit nationally. I think it was quite a struggle at one stage to understand how their organisation, how their model operates in comparison to other organisations. And this was to give them a bit of a baseline of what this might look like moving forward and to allow them to come with evidence-based conversations to say, here's the level of staff we've got in comparison to colleagues, what can we do about it? So again, very high level, but jumping onto inpatient services, and in our findings event in a couple of weeks' time, we'll break down some of those independent services that I mentioned. So for inpatient services, we're looking here at adult acute wards, PICU, CYPMH again, so Children's Services, and then any others as well. Again, this specification was designed in collaboration with some of those provider types, and we are open to feedback as to how that may develop. We've had some really, really good engagement, like I mentioned, and so it may well evolve as we move forward. So in the same vein as previously, we've got the pharmacists supporting bed-based services there on the left, and again, the total staff. And those total staff again include technicians and assistants as well. And you can see here, we're now benchmarking, rather than population, we're looking per 100 total mental health beds in the organisation. And so for pharmacists, again, quite a large range, but a median there of 2.3 staff per 100 total mental health beds supporting it. And that's again, pharmacists. Like I mentioned, there's quite a large range. So there's an organisation there you can see at nearing 10 pharmacists per 100 total mental health beds. And so kind of 1 in 10. And then some organisations down at nearing sort of 0.5 or 1 whole-time equivalents. And again, that was the purpose, right? To be able to allow organisations to compare what their staffing structures look like in comparison to some others. Touching then on the chart on the right, going back to total staff, so that including technicians and assistants, we're looking at, again, a slightly larger number, if not double the value that we saw before. So we're now looking at 4.26 whole-time equivalent total staff supporting 100 mental health beds. And you can see again a really, really large range. There's an organisation there at nearing 15 total staff supporting their inpatient service beds, and again right down at nearing 1 for others. So we're hoping that what this will do is kickstart some of that conversation, and we're hoping that again in our findings event in a couple of weeks' time, when we dive into some of this data, we'll really bring out some conversation between those providers as to what their structures look like and how we can support moving forward. What I also thought might be useful, so a little bit of last data to touch on today, is some of those vacancy and turnover metrics that we see quite frequently, particularly given that this was a kind of workforce specific collection. And we can see again that vacancy rates really do range between some of those organisations. We're looking at an organisation there at nearly 30% vacancy, with an organisation actually over-established at nearing 15%. So again, it massively depends on what the organisation look like and what type of care they're delivering. And we've tried to give a bit of an overview of that in some of the data that we've captured. You can see there was a median vacancy rate there of 6% from a total of 38 submissions to that question. And for turnover rate, we see something similar. And I think what this is really touching on is the need for this kind of data. We're really seeing a large variance across organisations, and we tried to ask some narrative questions in collaboration with this to understand what people's challenges are. And again, in a couple of weeks' time, we'll touch on what some of those are and some of the initiatives that organisations have in place to counteract some of those challenges. But I mean, one huge challenge that we've read through some of those narrative responses is that actually getting staff into the building in the first place is really, really difficult. There's a real challenge in terms of hiring those pharmacy staff to support the services, and you can see there with a median turnover rate of 9.4% that there is a large challenge in place. Some organisations going nearing, if not above, 20% turnover rate, and so there's definitely actionable insights that we can provide to people with the data that we've captured there. So I suppose a couple of next steps really, and part of the reason why we thought it may be good to present some of this data today is, like I said, we've got that dedicated lunch and learn session, and the time and date of it is there. I will share a link to anybody who would like to register. As I mentioned, I realise there's some pharmacy colleagues on the call and may or may not have registered for that event. The outputs are all available, as I mentioned, so people can have a look at what they look like. And again, it's a bit of a first stab for this sort of project, so any feedback is absolutely welcome. And that touches on my final point there. Um, this is a first iteration. This is a bit of a pilot exercise to see what engagement we got, and it was fantastic. And we've had some really, really positive conversations with providers from across the nations. Um, I'm more than welcoming any feedback anybody has on this data, and we would like to evolve it in some way if possible in the future. So please do take the time to have a look at any of those outputs. Please feel welcome to join that dedicated lunch and learn. You don't necessarily have to be a pharmacy specific colleague to join that, and it may provide some insight for you and your organisation. It will be myself presenting the data at that in collaboration with some others. So hopefully we can bring about some really useful conversation for any of those staff that are in those calls. And given the level of engagement I've had myself, I'm sure there'll be lots of conversation and things going on in the chat. So um, it was a really nice experience to be able to kind of put this together in the first place, and some really positive outputs. I'm hoping for some of those contacts that have been engaged and that have kind of taken the time to collect the data. And we're hoping again, as I say, that some of the outputs that we produce will be really, 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 really useful for those organisations. So thank you so much. I realise that was quite a whistle stop, and there's not loads, I suppose, to touch on, but I think that we've just got internal speakers after this, haven't we, Emma? So hopefully sticking to timescales, we might be able to give some people some time back.
Fantastic. Yeah, thanks, Dan. We're pretty much on time, just a couple of minutes ahead, so that's fantastic.